Welcome everyone to Managing CP in Adulthood, a Q&A webinar with Dr. Mark Peterson. The webinar is closed caption enabled, and as I just mentioned, I've turned on transcription as an accessibility feature. I've also turned on a poll to find out a bit more about why you're here. I'm Jocelyn Cohen, Vice President of Communications and Engagement with Cerebral Palsy Alliance Research Foundation, also known as CPARF, and I'm here in New York City. You're joining us during our signature month, September, which I'll share a bit about later. Thanks to our generous donors, we fund research for every age and stage, and one of our goals is to equip people with CP with as much knowledge as possible, no matter what their age or experience. I'm so glad you're all joining us today. As an adult with cerebral palsy, I've faced many challenges of my own, and I know I'm not alone in this. I know that it's hard for so many people to find resources, both here in the US and worldwide, once we're over the age of 18, and it can often feel like we've been dropped into the wilderness and need to find our own way out. The good news is that there are indeed medical professionals trying to help us do just that, and Dr. Mark Peterson is one of them. He is the Charles E. Lytle Jr. Research Professor and Associate Professor at the University of Michigan Medicine, Department of Physical Medicine and Rehabilitation, and he's also an active member in the U of M Neuroscience Graduate Program, Institute for Health Policy and Innovation, Michigan Center of the Demography of Aging, and the Michigan Institutes for Data Science. We're grateful to have Mark here today, and while we can't give personalized medical advice, our hope is that he can provide some guidance and answers to concerns that so many of you brought up in the questions you submitted. Just as importantly, we hope that Mark's work and presence here today helps show you that there are people pushing forward for us. There are people who will help and who will do as much as they can for the CP community. Mark, thank you so much for joining us. I have a bunch of questions that I've culled from folks. I will also look at the Q&A throughout, but I'm going to start with my cold questions. And the first one I have is, why did you start studying cerebral palsy?
Well, thank you so much, Jocelyn. I really appreciate the invitation to participate in this. And I really can't tell you guys how much even participating in this with folks is something that I don't, most scientists don't have the luxury to talk directly to folks. And so it's really a special opportunity for me as a scientist, and I really appreciate the invitation and opportunity. So as Jocelyn said, I'm a scientist at the University of Michigan. I study adults with CP. I study many other things, but my primary focus of work is trying to understand sort of the lifespan health for folks living with cerebral palsy. And most of my work has been in that space, has been done over the last 15 years. I have my professional resume in this area is just about 15 years of age, and my personal experience comes from being a father to a 12-year-old with cerebral palsy. So I have a personal connection, and I'm strongly committed to doing that. I have a picture of my son. If I can share my screen, I'll do that. Here is Marcus on the right, and his older brother, Jackson. This is a long time ago. So I think Marcus was about 2 in this picture, if you all can see, and then Jackson is 18 months older than he is. I have another picture of Marcus here from a couple of days ago on the trampoline, and then from yesterday.
Can't see the trampoline one.
Can you see this one on the?
Nope, I think you have to stop this. It's like if it's a new screen, you have to stop.
How about we try this one? This is the most recent. This is from yesterday, kayaking. So he kind of sits up front like the captain of the boat, and I do all the work.
Getting in a kayak with CP, I've done it before. It is an experience to get in and out of one. That's
so anyway,
awesome.
he's my motivation, and I am committed to this work through and through, and I really appreciate you guys taking the time today to ask questions and hopefully maybe learn something. I always say this to Jocelyn, I probably stand to learn more from you than you guys do from me. So that answers that question. I study CP because I'm very committed to trying to understand health outcomes among individuals with CP, but also hopefully protect against unhealthy aging and living. So that's the thrust.
I really appreciate you sharing that and sharing those photos. And we're going to dive right into the next group of questions. So the next one is, We've received a lot of questions about dealing with spasticity and tightness. Can you please explain the difference between the two and how they might contribute to pain, especially as we age?
So that's a great question. I feel like I knew that question was going to come up. Spasticity is probably the number one hallmark feature, symptom of cerebral palsy. And obviously it doesn't go away in adulthood. Most of the work, as you all probably are aware of, most of the research in medical care sort of centers around pediatric models. And so the reason why it's important to study adults with CP is it's not a pediatric condition, obviously. So even though it's treated very much like a pediatric condition, it is a lifelong condition, and certainly folks with CP grow up. And so understanding the health outcomes in adults with CP is just as important as understanding the health outcomes and symptoms in children with CP. So the difference between spasticity, which is basically an involuntary contraction of the muscle that's generated from the central nervous system to the peripheral nervous system, stimulating a muscle contraction that is not on purpose. Basically, it's involuntary. So it's a muscle contraction that cannot be controlled. And tightness is that basically spastic muscle is very much like a Charlie horse of a muscle, where there's involuntary contraction versus tightness, which is basically stiffness of the fascia that surrounds the muscle belly. And while there are treatments for spasticity, there's direct treatments, both clinically and non-clinical treatments for spasticity. For spasticity, tightness is treatable through exercise and stretching. And so it's really important to note that while spasticity can cause tightness, it is not necessarily associated with it directly. So if you have a spastic muscle and then don't move as a result of spasticity, over time, that can cause joint tightness, muscle tightness, and joint contractures. And so all of you who have CP, and especially spastic CP, would know this firsthand. And perhaps you've received, botulinum injections or other treatments for that. But just know that tightness is a product simply of fascia, that's a connective tissue that surrounds the muscle getting tighter and tighter. And that actually can be directly addressed through stretching and exercise. And another misconception that I want to point out is that spasticity, while it's painful and while it seems to be inhibitory to exercise does not make spastic muscle worse. So actually it can make spasticity management better. And so the old notion that exercise can lead to worsening spasticity is totally false. And there have been numerous studies now to show that exercise, and specifically resistance exercise, can actually help with spasticity management and can alleviate some of the effects of spastic muscle.
That's really helpful information to learn, because for a long time, I definitely use the two terms interchangeably. And as we age and have to deal with a lot more from our CP, it's helpful to know what we're really talking about. Am I saying that I'm more spastic right now or just more tight? So I feel I'm glad to have that information. I hope it's helpful to others as well. Speaking of aging, how can aging contribute to new sources of pain, and how does spasticity affect that?
Yeah, that's a great question. So, as you know, I've said this many times, cerebral palsy is considered in the medical literature to be a non-progressive neurologic condition. And yet I would posit that most people in the audience would say, but I've experienced progressive declines in my abilities to move. And that goes to stand for the entire population, but certainly in CP, there is progression. There is progression, not in the neurologic insult, but actually in the aging process. And so, with age comes greater risk for certain things, and pain happens to be one of those. And certainly, pain management is a primary issue in CP. It really is one of the most important things that can contribute to deviations in quality of life. And so kind of getting arms around pain management and the most appropriate pain management early in life is extremely important. But even in later life, having an appropriate pain management team is extraordinarily important, because pain doesn't just arise from CP specific mechanisms. It can be caused through various other mechanisms that come from sort of the central nervous system in the brain, but also the peripheral nervous system, which we would call neuritis, and musculoskeletal system. So if you have pain that comes from spastic muscle or joint dislocation or scoliosis, that's joint pain essentially. And there are other types of pain that can be treated completely differently. And so again, having a good primary care and CP, PM&R doctor to help with pain management is extraordinarily important, but it does coincide with age. And so the question is a really good question regarding sort of what happens with the aging process.
That, I mean, I've definitely experienced some of that, and I know that my friends have, and I'm sure that many of the people here today have too. Pain is, 75% of the 18 million of us with CP experience chronic pain. So the more we can do to help people with CP with pain, the better.
Yeah, and I think to follow up with that, I want to underscore very, very strongly that musculoskeletal pain coming from the joints, from the muscles, has always been what everybody has focused on, sort of in the scientific community, in the medical community, for CP. So pain management has been reduced or distilled down to that type of pain. And now the pain literature is becoming much more inclusive of other types of pain. And that's some of our more recent work, is trying to understand what we call the pain phenotype in CP. It is not coming from one location. It's chronic and overlapping pain conditions. And so if you feel like you're having pain, in multiple locations in your body, and it's being treated as an isolated condition, it's not necessarily being treated correctly, and it should be looked at more holistically. It's really, really important.
Is that because, again, the pain could be coming from your brain and not actually the site of where you're feeling the pain?
That's right. Some folks who report having pain in a specific site actually have no evidence of injury or overuse injury in that site under imaging. So if you look under imaging to see why somebody's experiencing pain in their knee, but they have absolutely no evidence of osteoarthritis or any other pain conditions in that specific location, it's not coming from that location. It's coming from another part of the body. And in this case, it could be coming from the nervous system, basically.
So we have to approach it, and the medical community has to approach it in a vastly different way than they have before. And you're doing
way.
that work.
Yep.
Thank you for that. So just in relation to the questions that have come before, how can people with CP take things into their own hands and work to potentially lessen their spasticity?
So I think it's not even specific to spasticity, honestly. It's really about your overall health profile. So your medical profile is much more than your gait, and much more than your spasticity. But spasticity is obviously a very, very important feature that needs to be addressed, because it does associate with pain. It does associate with movement and quality of life and independence. So maybe the most important thing that I could say this evening is that you need to be very, very, very strong advocate for yourself. In the US, we have, I know there's a few folks on the call today from outside of the US, but in the US, we have very much a fragmented healthcare system, and there is no medical home for CP, which is basically what would be perfect if there was something that way. It would be a coordination of care. And so especially as a child with CP transitions off of their parents' insurance, they are often left to navigate this healthcare system that's fragmented and to try to understand how to coordinate, care among multiple different specialists and providers. And so if somebody doesn't know to do that, their primary care doctor will not do that for them, unfortunately. And so I would really strongly recommend that, through great organizations like the CP Alliance Research Foundation and other like foundations and organizations, if you can find folks, and I'm certainly willing to help people out too, and I will provide my contact information. It's really, really important that you take this and be your biggest advocate, so that you can start to coordinate care among providers, because they don't talk to each other. I don't know if you don't know that, but providers, even at great institutions like University of Michigan, providers across the street don't talk to each other. And so you really have to be your own best advocate to put people together to coordinate care among your primary care physician, among your physical medicine and rehab physician. So for those of you who don't have a physiatrist on your team, you absolutely have to find a good physiatrist who has some knowledge about CP. we'll talk at some point, I think tonight, about mental health, having a therapist, a psychotherapist, a psychologist, someone who is a behavioralist, somebody who is able to talk to you about your mental health. Critical, absolutely critical. And so these different providers definitely don't talk to each other, and they are not going to be there emailing you to try to schedule an appointment. But it is critical that you do have some of these different providers, an internal medicine doctor who you can talk to about your bone health, your metabolic health, a cardiologist who you can talk to about your heart health. I mean, that may seem daunting, but it's in your hands to make these connections with folks, and really try to take your health sort of in your own game, because it isn't going to be done by anybody else.
I really appreciate that, because in my experience and the experience of several people I know, it can get cumulatively exhausting to navigate the system, to go see a new doctor, to figure out whatever new issues have arisen. And it takes a lot of time and energy. And, as you know, CP also just takes more energy to exist with. But I agree with you that it is really important to make it a priority. And perhaps even if you don't necessarily have the energy to do it, maybe delegate someone to do the emotional labor or the research, and team up with you, like one of your closest friends or family members, so that you might not have to take it all on solo, because it can be daunting. And related, we have a few questions in the Q&A about specific other conditions, like if there's any research on chronic kidney disease in adults with CP, or is there any relation to CP and high blood pressure? And I think what you were saying speaks to that, but if you have any more information to share on those, feel free to do that too.
Sure. So yeah, I mean, that's a great point. We've studied essentially every organ system in the human body in the context of health for individuals with CP. And what we're finding is that there is some risk for what we would consider to be like a premature aging in CP, which means there's higher risk for chronic conditions prior to being an older adult. Typically in the US, we would say, age-related conditions like cardiovascular disease and diabetes and dementia and osteoporosis are things that affect adults over the age of 65. And what we're finding, and including kidney disease, what we're finding is that they're happening at an earlier age for folks with CP. And that is not meant to be a scary commentary. It's more of it's just a highlight on something that has never been looked at. So one of the other reasons why I became fascinated with studying CP is that, not so long ago, 10 years ago, there had been essentially no studies on health outcomes in adults with CP. There have been studies on adults with CP, but there had been no studies on what happens to adults with CP as they grow up beyond the age of 18. And that blew my mind first and disgusted me second. So that's kind of where we started to chip away at trying to understand the progression of age in folks living with CP. And so, yeah, there is evidence of early onset kidney disease. There is some evidence of early onset dementias, and there's obviously quite a bit of evidence on early onset frailty, which constitutes muscle weakness and a risk for osteoporosis, so bone health declines. And so these are things that are very treatable, first, and they're also preventable, which I think is extraordinarily important to the message that I want to convey. I'm one of those folks that thinks exercise is the silver bullet for pretty much everything, including, conditions from the neck up. And so for all of us in the audience, I mean, exercise is a very potent stimulus to improve and maintain health pretty much in every single organ system. So there's certainly limitations to doing exercise on a regular basis for some folks. And exercise can be modified in about 1 trillion different ways. And so I want to say that it's not necessarily a scary, depressing commentary. It's just that it is the case. And we're starting to find that we need to get our arms around these issues so that we can firstly prevent, and then secondly, treat folks before the disease progresses to the point where it's not treatable. So it's really important to know this information, to equip with going to your primary care doctor who may or may not know anything about CP. I don't know if anybody in the audience can echo this sentiment, but I have had conversations with adults with CP who have said, my primary care doctor told me that I can't have CP because I'm an adult. Okay, so that to me is
No.
really hard to hear. So if you can echo those sentiments, it's your job to inform your doctor and then to go out and find a new doctor. No, I mean, to go out and find some specialists who might be able to.
I did that once. So, you know, I was at a doctor once and a medical student said, oh, it's nice to treat you. I've only ever treated normal people before. And she ruined my day with that. I didn't know what to do with it. So I found a different doctor.
Yeah.
But all of what you said is important because when you hear that information in isolation or by itself, it can sound scary, like all these conditions to look out for, but it's really just kind of a reminder to maybe eat a little bit more healthily and bring it up to your primary care doctor. If right now you only have a primary care doctor, just make them aware that you heard these things so that they can be on the lookout and maybe test you for something that they might not have tested you before, or monitor you for things that they might not have monitored you for before.
Right. For example, one thing that pops into my mind just right now as we're talking is that in men with CP, there's a higher risk, a higher prevalence of low testosterone. That's just one of those one-off things that, like, if you know it, you can treat that. That's a problem that can be treated. Hormone replacement therapy is very commonplace right now. Mental health conditions in CP are another thing. If you don't have a doctor that you can talk to about mental health, it won't be treated. So that's an extremely important thing to be able to equip yourself with the information so that you can help to improve the clinical awareness around these things. I mean, we together as a group, we should really work on trying to improve clinicians' knowledge, frankly, because it isn't there in medical school. It just isn't. So
right. There's a question from an anonymous attendee that sort of builds on two of the things you were talking about. And they say, how do you balance exercise while still allowing yourself to rest and live life normally? Throughout my life, there's always been a heavy insistence on exercise and stretching, and now I feel bad if I don't stretch enough or exercise enough. Do you have any advice on balancing the responsibility of managing CP versus blaming and guilt and being able to just live life without thinking about CP so much? I feel that deeply, so I'm looking forward to your answer.
Yeah, I mean, it's such a good question. I wish I could provide the best answers to all of these questions. Managing exercise it shouldn't be thought of as a chore. One thing I've heard like 1,000 times from the adults with CP that we see is that physical therapy is a 4-letter word, and I can appreciate that sentiment. Honestly, I can really appreciate that sentiment. I know my son doesn't like going to PT. So really trying to make it more fun and think about it as something that's like a part of your day is really important, and a non-negotiable part of your day. And if you don't happen to be able to get to it, then it's not something that you should feel guilty about. It's not something that you should feel like, I failed and have not done my job in this area, in this regard. I simply bring up exercise because it is something that can be done out of the confines of physical therapy in a way that might be enjoyable in a recreational sense, and that you could benefit from it as well. So, my colleagues in the Netherlands, for example, say, everybody with CP wants to continue riding bike. We have adaptive bikes for folks with CP because they want to do it because that's what everybody does. And if you've never been there, literally everybody rides bikes in the Netherlands. So, if you can couch exercise in the form of something recreational or enjoyable, it doesn't need to look like we've done a terrible job in the United States. Actually, I don't care if it's for this population or any other population. Exercise has been packaged in a way that is so unattractive to a very large segment of the population. In fact, most people don't exercise. So, and that's not specific to CP, but literally 3/4 of the United States does not do exercise. So
Wow.
really, really, really important to note that it doesn't have to look and smell and sound like the way we've packaged exercise. We've done it in a terrible way. If you don't have a personal trainer and Lululemon gear and go to a beautiful gym with a personal trainer, it doesn't matter. You can still be active and get out and move and benefit from being outside if you like doing that. I've talked to Jocelyn many times about don't worry about exercise. Just go down your stairs. That's exercise. Go down the stairs. But there's a million options for adaptive exercise, and that doesn't necessarily have to take place in a formal gym. I understand that there's lots of reservations and barriers to gyms, and it's disappointing, frankly, that we in the United States we have done almost nothing for inclusive training for folks with physical and cognitive impairments. So that question really resonates with me, and it's something that I think about a lot, actually.
One piece of advice I'd offer from the palsy perspective on this is don't make your goal a big one. Do it in a bite-sized way. We recently posted a seated yoga video. It's like 15 minutes on our YouTube channel and on our socials. And that could be a good way to start, whether you're someone who's a wheelchair user or not. If you feel like using your legs too much in any kind of way is too exhausting, start with something where you're just using your arms and you're sitting down. People tend to think maybe that if you're not using your legs, then you're not working out, which is ridiculous, but again, goes to exactly what Mark was talking about. So maybe start in small ways and set smaller goals for yourself. And if you've made any sort of progress, then you've achieved your goal, as opposed to like, did I exercise or did I not? If you've made any sort of progress, then you're doing a good job, and don't berate yourself too much or at all if you don't do it. That's something I deal with too. So I really do appreciate the question and Mark's answer.
Yeah, and if I can add one thing to that, I just was on a dissertation defense for a PhD student in Canada who did a study in spinal cord injury, and actually found that upper body exercise elicited a better response than did aided walking exercise for folks with spinal cord injury. And so if you don't feel as though using your lower body is possible or attractive, there's a lot of upper body exercises that can be done, both for aerobic and strengthening exercises that are also really beneficial. So I have to just kind of really support the comment that you just made, Jocelyn, with that.
I will look into those things because I feel like I'm more likely to do them. Thank you for that. So what are, well, you sort of talked about this with working out and everything, but do you have any other things to add when I'm asking what are the best things someone with mild or any type of CP can do to prevent pain? Is there something other than exercise that you would recommend?
Sure. I mean, of course, as I said, exercise is going to come at the top of the list for me. The other major thing that contributes to onset of pain, especially centralized pain, or we used to call fibromyalgia, is sleep. Sleep disturbance causes pain. I know that sounds weird because why would sleep cause anything to do with pain? But there is an enormous body of literature that shows that poor sleep habits, poor sleep hygiene can really cause some issues related to pain. And so I would say, first exercise or some kind of movement, and then secondly, address sleep if sleep is an issue. And there's quite a bit of evidence that folks with CP through various mechanisms have disturbed sleep. And so I really think that if sleep can be addressed secondly, and obviously I think healthy nutrition, it goes hand in hand with exercise, it really can be something that can go a real long way. And stress management also tends to, I don't know about anybody else, but for me, stress, I'm always in back pain if I have stress. And so tight muscles, stress, no exercise, and poor sleep is a direct recipe to have pain.
Yeah,
and
I mean,
in fact, we have a pain researcher here at University of Michigan who is world renowned and has several really large grants to look at the role of sleep across populations. And it really is powerful. It's really powerful. Improving sleep seems to alleviate pain in up to 50% of patients who have chronic pain.
that is, I mean, I am a long sleeper and I've always been a long sleeper, and that might be a piece of it too. I also know I learned a few years ago, and it still blows my mind, that the muscles in your lower back loop up to your shoulder. And I know that because my legs are tight from CP, they're pulling on my lower back. So essentially, sometimes when I'm stressed and my neck hurts, it's because of my legs. So everything just builds on itself. You have the neck pain from the stress and the neck pain from the tightness from the legs and pulling everything else. Yeah, I mean,
Well, and even movement, if you have pain and or an orthopedic condition and you have and then you need to compensate for that and you're forced to ambulate, you could have a referred pain in another location in your body that had nothing to do with that at all, and nothing to do with your shoulders. But now you have terrible shoulder, you have a spinal stenosis because you had poor posture because you forced yourself to walk across town instead of taking, a ride or chair. So I have come full circle actually in my career to appreciate using assistive devices when needed and not forcing oneself to do something because it's what you think you should do. In fact, I say that without hesitancy at this point, because when you force yourself to go across town when you know you're in pain and you put yourself in a compromised postural position, or your gait is off for a reason that you slept poorly or you have a stiff neck, you're going to potentially compromise yourself further. So it's okay. It's okay to allow yourself an assistive device in that capacity.
I appreciate deeply that you said that, because it's a conversation that happens a lot around the CP community. I don't currently use an assistive device. I assume that at some point I will. But the way that I talk about movement is that the way you move should allow you as much energy as possible once you've gotten from point A to point B. If you exhaust yourself as well from A to B, then you can't even do the fun thing that you were trying to get to do. And, detaching whatever shame is connected potentially to using a mobility device, or potentially to losing mobility that you might have had, or never being able to achieve mobility that others thought you should have or would have achieved, just because we live in a world that's built for people who walk. There's so much packed into there. It goes into the mental health piece that you were talking about before as well.
Right. And to piggyback on that comment, Jocelyn, one thing that I'm sure will probably resonate with everybody is that what you do to get across town or climb a flight of stairs or engage in your physical surroundings is consistently and significantly harder than somebody that doesn't have CP. So what that means basically is you have to use sometimes up to 200% more energy to do the same task. And that energy is actual real energy that you are devoting to that instead of something else. And so heart rate, respiration, all of the things that go into moving your body is significantly higher to move across space than it is for somebody that does not have CP. And so there's a lot of work in that area too. And so, the energy cost of movement is far greater for folks who have spastic muscle and who have physical limitations than it is for somebody that does not. And so I want to really underscore that point is be kind to yourself, because, getting across town to play an adaptive tennis, that's great, but just get yourself over there. Don't try to walk across town. It's okay. Just go over.
So someone asked this question, which is, they don't have access to PT anymore and they do exercise 4 times a week. Is exercise something that can replace PT?
Yes, I love that question, actually. So again, PT has been, it's just different here in the US compared to other countries that cover PT. And so if PT is not reimbursed because of whatever insurance you have, and it's probably not, then there's other options. Obviously, some physical therapy clinics would offer personal training, and then some don't, obviously, and some are you should steer clear of, just in general. But I am very much a proponent of just engaging in physical exercise. And if you can get a program from somebody that has some experience with CP, then even better. But don't borrow from your childhood days of going to PT and try to replicate that. It's really it's just boring. So it's okay to do some of those exercises, certainly, but it's extraordinarily important that you enjoy what you're doing, because we all know that if you don't enjoy it, it's just going to end up being on the chopping block. So I'm a proponent of my PT colleagues and what they do, and I love what they do. But it's not the end all be all after your insurance runs out. And there's a lot of other options that you can do and adaptive recreational opportunities, adaptive sports, adaptive climbing. My son does therapeutic horseback riding. There's a lot of things. And then somebody put in, I believe in the chat, maybe one of the best things that I've neglected to say is getting into the pool.
Yes.
So the pool is first, it offers the buoyancy of the water, offers the ability to unload your body, and then the water creates basically a 360-degree top and bottom resistance exercise program. So any which way you move, you're moving against resistance. So the pool is one of the best places that you can be. If you can find a place that has a ramp or a lift, or if you can get into the pool however you want, then the pool is a really great way. And we've had folks who are GMFCS4s run in the pool because they're so unloaded that they can actually move. They can move inside of the pool because of that reason. So really important to be, I don't know, to be creative, but also to engage in things that you enjoy. One of my colleagues at UNC Chapel Hill, Deborah Thorpe, is a big proponent of pool exercise. And so I definitely agree that getting into the pool is something good, but it has to be enjoyable. It really has to be enjoyable.
Yes. You just mentioned GMFCS4. That just means that's someone who uses assistive devices most of the time. Is that accurate?
Right. Yep. Okay. Non-ambulatory must use assistive devices to ambulate and move around. And
so then they can walk or run in the pool.
Well, because again, the buoyancy takes off, a huge percentage of your body mass. You can, and if you use flotation devices, you can do even more. Yeah.
I went to an adaptive swim class for several years when I was a kid. I used to be able to swim the laps, and I always said it felt like I didn't have CP when I was in the pool. Exactly. And if I could live in water, it would be great, but that's not how our world is built.
That's literally exactly what people report. I don't feel like I have CP when I'm in the pool.
Yeah, it's magical.
Yep.
Yeah, so
and I can't get my kid out of the pool too, by the way. Like the only thing he wants to do is swim.
Yeah, you're like, well, we can't walk around in water all the time yet anyway. You sort of alluded to this earlier, but in case you have other specifics, would you say that bodies with CP age quicker than those without CP?
So I don't like to say that age quicker because that sounds really, really bad. But what we found is that even young adults with CP have some evidence of increased risk for what we are calling non-communicable diseases. So a communicable disease is an infectious disease like COVID. A non-communicable disease is something that comes because of something else, and it's usually age, right? Or physical inactivity, sedentary behavior, poor nutrition, smoking habits, things like that. Those are things that cause non-communicable diseases. And so we have found that even in 18 to 30-year-old adults here at University of Michigan Clinic, there's some evidence of early onset risk for some of these, what we would say classically are age-related conditions. And so age faster, not necessarily, but we do see things that are concerning much earlier in life. Frailty is probably the most prominent early in life. And so when I say frailty, basically I'm referring to the musculoskeletal structures. And so muscle and bone is even from childhood blunted in growth, and then in terms of adaptation as an adult, there is less of it essentially. So there's less muscle and less bone. And so what does that mean? Well, bone and muscle are both very adaptive organs, and so they can adapt to loading and unloading. And when I say unloading, that means not moving. When I say loading, that means moving as much as humanly possible. And so muscle is highly plastic, and bone is also quite adaptive as well. And so those two tissues, they are connected to each other. And if you can engage muscle, you can engage bone, and you can also stimulate both muscle, what we call hypertrophy and strength improvement, and bone proliferation or bone health improvements too. So these are preventable conditions, but they do require some loading and some stimulation. There's obviously pharmaceutical interventions for bone, not many for muscle. Obviously, if I alluded to earlier, some men with CP may have low testosterone, and that's a very potent anabolic hormone that can help to improve muscle mass. and it's widely used, and there's no stigma at all behind approaching your doctor about testosterone replacement therapy. And that's something that, that didn't used to be the case 10, 15, 20 years ago. Nobody would talk to their doctor about things like that. So if any of the men in the audience haven't done so, I would encourage you like right away to get your testosterone taken, because that is an easy fix. And so same thing for women. I mean, have a blood panel taken so that you have an idea, everybody, a lipid panel, so you have an idea of your cardiovascular risk. And that also gives you an idea of metabolic health, but also, a hormones assay as well, which would tell you sort of what your hormones look like and if it's in the normal range, because very treatable.
That's helpful. And it goes back to what we were talking about earlier, just in having a whole care team and being holistic about your care. And just, I know that for some period of time, I used to attribute things to my CP, and then I realized you shouldn't do that. This could be something else. Go get things ruled out, go have these conversations. And I think, some of us, again, can get exhausted by going to doctors for so long that maybe people will put things off or just not want to do it. And you're just giving all these great reasons why people should go, should reach out, should find new care if they don't have it.
Yeah, and I think in this day and age, care is better and is coming to you more. And there's certain downfalls to telemedicine, but I do think that there is some advantages to it as well for folks who are maybe in a more rural area, have less access points for clinical care. So don't rule out the power and potential for especially mental telehealth in the near future. So if that's something that those of you in the audience haven't tried or haven't considered, that is something that we're really pushing folks to consider, because there's very few providers who know anything about CP. And so to reduce it even further by having to drive across a state from northern Michigan to where we are in southeast Michigan, people just aren't doing it. And so consider telemedicine as a potential access point, especially for mental health and behavioral health.
It's a good access point as well as an introductory one. So if you are willing and able to eventually travel, like starting to see a doctor via telehealth will save you a ton of money and time and physical and mental energy. You can have that first appointment and see if you like that doctor and if you want to spend more time investing in them as your care person, and then decide if you want to travel. And they can also answer your questions about accessibility of their office, if they have tables that go up and down, if there's issues at the entrance, if there's accessible parking, things like that, so that you don't have to worry and wonder in the way that you would have otherwise if you were just going to a first appointment in a physical office.
Yeah. So that's where I get to learn more from you than you do from me. Those are questions I wouldn't even think of, Jocelyn.
Yeah, it's like, why doesn't every office just have a table that goes up and down? Frankly, exactly. For anyone, because someone just could be older, it could be harder for them to get on it. And I always have to ask 2 or 3 people to help me up. The thing that pulls out from the bottom is a really high step, and it's awkward. And yeah. And then I have the ability to get on a table, but then if I'm a wheelchair user, how am I weighed at the doctor? There's all kinds of things. And then when you've experienced that for so long, it is cumulative and you kind of want to avoid it. So you can ask those questions when you're doing telehealth and kind of weed people out if they're not going to work for you, or if their physical office isn't going to work for you either.
Yeah, I love that. Yep.
Yeah. And so we had a bunch of questions pop in through the chat and beforehand. Why is fatigue much more obvious as an adult? The person that submitted that question said they're using their wheelchair more often. And as a tandem to that, someone asked about energy expenditure and if this applies across the CP spectrum, including GMFCS1.
Yeah. I mean, those 2 questions go hand in hand. So thanks for putting those together. Just in general, age is a prime predictor of fatigue. And so for anybody, and so for somebody who already has physical impairments, fatigue is a huge problem. So I neglected to say something about fatigue, but it's very much a hallmark of CP. Fatigue comes from, as I alluded to earlier, and to the second point, is that the energy cost of movement is profoundly higher for folks with CP than they are for folks without CP. So what it takes me to walk across the room or climb a flight of stairs, it may be fivefold increased for a person with CP who has especially spasticity and weakness. And so energy expenditure much higher for a given task, and fatigue is going to be as a sort of side effect as a result of the high energy cost of movement. And that's been really well documented even in the clinical literature, in terms of oxygen consumption for a given movement pattern. And so we put folks with CP, especially quadriplegic CP, who have to ambulate, and we look at actual energy cost and heart rate response and respiration, and it can be upwards of 80% of VO2 max and heart rate max even when walking. And so does it have the same impact on cardiovascular fitness? No, it's not like you're running, but it definitely has an impact on fatigue and resource utilization, I would say. And so if you're utilizing all of those resources to do something that doesn't require those resources for somebody without CP, it's definitely going to cause a huge uptick of fatigue.
That's helpful to know. I had a theory as a kid that I was a champion napper because CP made me more tired, and you've just solidified that. So I had a few more questions pop in. A really quick one related to what you were saying earlier about testosterone. If someone is 55 and male, is it too late for them to get on some testosterone supplements, or would that be helpful for them?
No, that would be very helpful for them.
Okay.
Yeah. So that's an easy, as I said, that's an easy fix. We just you get a whole testosterone panel done, and that's not something a doctor would typically do. So you have to advocate for yourself to get that done. And if it turns out that you have normal testosterone, they're not going to prescribe any treatment, obviously. But if not, that's a really easy fix. That's a real easy fix, and people really report significant changes in the way they feel after. And certainly, if you exercise and have testosterone at normal levels of testosterone, it's going to be much more effective too.
That is good to know. So I have a few more questions I'm going to try to combine. One of them, our friend Todd asks what you're most excited about in your current research. And then as sort of a dovetail to that, how can lay people with CP learn more about the research that has been done on adults with CP beyond webinars like these? One of the things that's most frustrating to me as a young adult with CP is not knowing what I am more at risk for as I age, or what I might be more likely to experience as a young woman with CP.
Yeah, I mean, that's what I get excited about. I get excited about disseminating information that could potentially help hopefully thousands of people. This is not about me, and it's not even about my own son. It's about helping folks with CP prevent some of these totally preventable chronic conditions that has nothing to do with CP. So to me, the fact that there was nothing in the literature on health outcomes in CP circa 2010, it's just crazy to me. I mean, it's actually really crazy, and it's owing to the fact that CP has been considered historically as a pediatric condition, and so you can't have CP if you're an adult. So that's just something that we have to get rid of. And so to Todd's question, I think as I approach sort of mid-career, what I'm most excited about is taking all of the work we've done and going, okay, we now know what needs to be done. Let's start training new doctors. Let's get stakeholders involved. And I want to see policy amendments at the top level so that folks with CP have coordination of care when they transition from pediatric to adult care. And that transition should be helped by smoothing out with healthcare navigators, help families, and then there should be essentially a medical home for folks with CP, or at least the availability of a medical home for folks with CP. There are for other conditions, there are for patients who are being treated for cancer. I just think that there's a need for coordinated care, and that's going to happen only with improved clinical awareness, improved clinical infrastructures, and then changes in policy. So that has to happen. And so if my work doesn't go beyond research dissemination in medical journals, I've wasted a lot of my time. And so we really have to do more now, kind of moving forward, engaging and emboldening stakeholders to do this. Let's work together to create toolkits to help to improve the clinical awareness of what folks with CP need when they grow up. And then let's go to Capitol Hill and get some changes in policy so that we can see this happening, worldwide, nationwide. Because it's one thing for it to be at Columbia, at Michigan, at Nationwide Children's, at these large medical centers. That doesn't help most of the people with CP. Right. It needs to be something that's policy and is part of law, frankly.
I've said this like 5 times in this webinar, but I deeply appreciate that as well. The multi-pronged approach, the fact that, can't just be solved by one person, one institution, 10 people or 10 institutions. It's really a holistic issue that needs a holistic solution. My last question is going to sort of combine other questions, and it has to do with mental health. Someone had said, they're a therapist with CP. Do you study emotional impact as we age, often with increased pain? And as a corollary to that, someone stated they're on antidepressants and anti-epileptics due to mental health conditions. Will these have a negative effect on my CP in the long run?
Yeah, I mean, that's maybe one of the most important things that we've done in that question. And then the things that we've done in the last probably 3 years is start to look at mental health. I'm not a psychologist, I'm a physiologist. And so trying to understand mental health is outside of my lane, but nobody else was really doing it. So we started to do some work 3 years ago after clamoring of patients, caregivers, and other folks asking about mental health, concerned about mental health. And so, yeah, there is certainly an association between pain with CP and mental health. And we have a recent paper that was published by a colleague of mine in our group, Daniel Whitney, who looked at the effect of pain on mood affective disorder. So that's essentially depression, anxiety. And there's a robust association between existing and newly onset pain conditions and diagnosis of mood affective disorders and CP. We've published subsequently 5, 6 other studies to look at mental health and psychiatric disorders in CP, and there's higher risk for developing, multiple categories of mental health and behavioral health issues in CP. And so we need to better train, obviously, therapists and mental health providers to understand the nuanced unique needs of adults with CP too. But I definitely think that this is something that affects children with CP. And so setting a precedent that there is issues in adulthood. So one time somebody asked me, why don't you care about kids with CP? Not knowing that I had a child with CP.
Wow.
And to that I say, if you don't know what happens in adults with CP, you don't know how to treat children with CP. And so these health outcomes that ultimately arise in adulthood need to be treated earlier. They need to be treated or prevented from the time that the person is a child. And so mental health care is really, really important. And I think that question is certainly, if the person is a therapist, they have CP, they really have a lot to contribute to the community. And one thing that we don't have is a lot of mental health providers who know anything about CP. So that's the other issue.
So, one thing I'll say, well, 2 things. I learned at a prior American Academy of CP and Developmental Medicine conference that there are certain SSRIs that can make CP worse. I don't have that in front of me. I think that research was published. I will go ahead and look for that. And if and when I find it, we'll send it out to everyone who signed up for this webinar, so that you have that information, because the last thing anyone would want to do in treating their mental health is to unknowingly worsen their CP and worsen their motor function. So I'll look into that. The other piece is that when I speak with parents of young children with CP, I recommend adding mental health to the therapies that are being done, because when you're a child, things are being done to you, you process them in a childlike way, and you don't understand that they're helping you even as they're hurting you. And even if you sort of do understand it, it can be a lot of trauma, it's physical therapy, it's potentially surgery, it's painful braces, alienation, all these kinds of things that can come in childhood. And so I would hope and recommend that the medical community, adds the mental health for children piece into the recommending physical therapy and speech therapy and occupational therapy.
Yeah, and your point is a good one, that there are issues in childhood like bullying and exclusion and abuse, frankly, that can really set the stage for mental health disorders across a lifespan. These are things that last an entire PTSD, last an entire life. And so mental health provisions in children with CP, with developmental pediatrics, or some version of that is really, really important.
Absolutely. So we're closing in on the end of our time, and I just wanted to say we appreciate everyone's willingness to listen, the vulnerability you shared with the questions you asked, and we know there's so much cerebral palsy research to be done and so many questions that still need to be answered. And to that end, I know we couldn't get to all of your questions, but we will share some answers on our blog in the coming weeks. And as Mark mentioned, he's open to your outreach. He can be emailed at mdpeters@med.umich.edu, which I will also send out when I send out the SSRI information. And we plan to do more webinars like this in the future, so stay tuned for details on those. If you're interested, we do hope you'll consider giving back to or sharing our ongoing September campaign. You can donate at www.steptember.us, and tomorrow is an especially great day to do it, so keep an eye on our social channels for more info on that if it's something you're interested in. When you give back or amplify our work, you'll be moving cerebral palsy research forward for yourself and for all of us. And I hope that you enjoy the rest of your evening. I really appreciate that all of you were here.
Thank you so much again for the invitation to be a part of this.